Okay, ladies and gentlemen, anyone to hear my voice? Uh, because of the time, we are a little bit delayed. Now the second session in the morning will be started. In this session, Professor Dale King and I will co-chair this session. I'm the Dr. Senfa Shi from Veteran General Hospital Taipei. And we have two speakers in this session. The first speaker will be Professor Kunihiko Kodama, and the second speaker will be Zhenjia Li, who will be introduced by Professor Dale King. And the first speaker, Professor Kodama, he's from Shinshu University Department of Neurosurgery. He's the students of Professor Kobayashi and Professor Hongo, and he also did clinical fellowship in Australia under Professor Andrew Kay. And he also did research fellow in Germany with Professor Seifert. And his subspecialty is especially in skull-base surgery, cerebrovascular surgery, and intraoperative neuromonitoring. So today he would like to talk about the intraoperative neuromonitoring for cerebrovascular surgery. And welcome, Professor Kodama.
Thank you very much for your kind introduction. Can you have my slide, please? University, Japan. So let's talk about intraoperative neuromonitoring for cerebrovascular surgery. So this talk contains of the surgery and intraoperative monitoring of the intracranial aneurysms. Also, I will refer to the surgery for the IO and IOM of the arteriovenous malformation here. So let's start with the surgery and IOM for the intracranial aneurysms. As you know, the intracranial aneurysms are divided to the sacral, fusiform, and dissecting aneurysms. Sacral aneurysms penetrating about 1% of the population. Rupture risk estimated on large observatory studies such as unruptured cranial aneurysm study in Japan and Freddy's score estimated rupture risk by scoring. Also, computed flow dynamics study can calculate the rupture risk for each aneurysm characteristic. As for the treatment modality, the craniotomy contains of the neck clipping of the aneurysm, trapping or proximal ligation of the parent arteries. And the vascular procedures contains coil embolization and flow diverters. And sometimes combination of these procedures are used. And this is a neck clipping on aneurysm, trapping without and with bypass, and proximal ligation with bypass. As for the endovascular treatment, coil embolization is illustrated here, and also have the flow diverter here. Clipping surgery is elaborated in nearly early 90s and widely spread since 1970s. Long-term outcome are reported favorable and stable. Coil embolization is developed nowadays since 1990s and less invasive, and developing new devices year by year, and long-term outcome is uncertain. Sometimes coil compaction happens and retreatment is needed. Titanium alloy used for the aneurysm clips. This is the Professor Sujita, first professor in the Shinshu University. He developed Sujita aneurysm clips, which is widely used worldwide nowadays. And here is the Professor Gazia Sazir, which is another giant for development of the aneurysm clips. Let's start with the illustrated cases. Here is an internal carotid and anterior choroidal artery aneurysm with a diameter of the 11 millimeter, Page score up to 10 and 5-year rupture risk was 5%, 5 to 5.3% per year. And this is the preoperative imaging showing the posterior communicating artery here and anterior choroidal artery here. So the adjustment of picture window and width is very critical to plan the preoperative strategies. This is the intraoperative video, and the right optic nerve internal carotid artery aneurysm here. So the secure the proximal artery here, and place the temporary clip and dissect aneurysmal dome from the temporal lobe. Place the temporary clip, reduce the dome pressure of the aneurysm. You can see the lacrimal space and tentrium here. Also dissected the distal part of the dome from the temporal lobe. ICZ before clipping, you can see aneurysm here. Under the temporary clipping, the aneurysm was clipped with a long straight clip here, and combined with a curved clip to the distal neck of aneurysm. New endoscope here is installed to observe behind the microscope. You can see ICA here, internal carotid artery here, and clip blade here. Aneurysm nicely clipped, and ICA and PCOM artery is preserved. You can see here the ICZ. This is the PCOM artery and anterior choroidal artery, also well preserved. This is a time course of MAP monitoring. You can see the MAP waveform here. During the temporary occlusion, the MAP potential MAP is gradually decreased, and after occlusion of the temporary clip, you can see it, recovery of the MAP here. Aneurysm clip was nicely clipped post-operative imaging and no neurological deficit post-operatively. So standard setup for us is MAP is suitable for the corticospinal tract monitoring. Transcranial stimulation and muscle electromyogram is recording is adequate. Rarely needs transcortical stimulations. Threshold stimulation we use routinely, or supramaximal stimulation is used for the another institutes. Control update before critical manipulation is needed for the precise and reliable monitoring. SEP is suitable for the ischemia in the cerebral hemisphere, but not as sensitive modality as MAP for corticospinal tract integrity. Let's talk about the critical surgical steps for the aneurysm clipping. What to be anticipated? Firstly, temporary occlusion of the proximal artery, parent artery. And this technique is used for to reduce the aneurysmal dome pressure to dissect, or to control the intraoperative bleeding from the aneurysm. Ischemia of the parent artery territory, SEP is more sensitive than MAP unless corticospinal tract is involved. Ischemia of the perforating artery supplying corticospinal tract, such as anterior choroidal artery, ventricular striatal arteries, MEP is more sensitive than SEP. So in this during this stage, IOM may suggest safe occlusion duration and critical timing to release the occlusion during the temporary clipping. And IOM can suggest safer timing of repeated occlusion by temporary clip. The second critical surgical step is neck clipping of aneurysm. Occlusion or stenosis of the branches may happen. Patency of parent arteries. MAP is more sensitive than SEP. And patency of cortical branches. SEP is more sensitive than MAP. So in this stage, IOM can detect ischemia of branches and suggest repositioning of the clips. Let's move on to the surgery and IOM of artery venous malformations. So let's summary about natural history, surgical indication, and surgical strategies. So natural history, rupture risk is reported 2 to 4% per year, and re-rupture risk is reported 6 to 18% per year once AVM is ruptured. So you may know about the spectral Martin grading system. And this is composed of 3 components with the nidus size, location of nidus, eloquent or non-eloquent, and draining system. So grade 1 to 5, the as increasing the grade number, you can see the mobility is getting higher. This is a recent report saying the same result. So from the American Heart Association guidelines, spectral marching grade 1 to 2 is recommended for a direct surgery. 3 is recommended for surgery, sometimes combined with endovascular feeder or nidus embolization prior to surgical resection. 4 to 5 has a certain surgical risk, so treatment options need to be discussed meticulously before surgery. Balance of the relative risk and the benefit should be also into the counted, should be included in the considerations. Surgical strategy is divided direct surgery, combined surgeries with endovascular embolization or radial surgery. Surgical strategy. Let's move on to the illustrated cases. This is a 13-year-old girl presented with a headache and right hem paralysis. You can see the subcortical hematoma in the left parietal occipital region. And CT angiography showing the AVM. This is the vertebral artery angiography showing the nidus here. You can see the feeders from the 1, 2, 3, and 4, 5, 6. Feeder 1, 2, 3 is feeders from arising from the inferior posterior temporal arteries, and 4, 5, 6 are from the parietal occipital arteries. So we plan the feeder 1 and 2 for embolizations. You can see the feeder embolized here, and here is the drainers 1, 2, and 3. This is the pre-operative plan: craniotomy, hematoma removal, and proximal secure of the posterior cerebral arteries, and feeder occlusions, and identify the dissection, and confirm the nidus obliteration by indocyanine green angiography, and ligate the final drainer and cut. This is the pre and post-operative microphotograph. You can see it. Nidus are nicely removed, and no AV shunt is left. Only normal drainages are observed. This is a post-operative course. You can see the nidus are nicely excised, no AV shunt. Another case, this is a spectral matching grade 4 patient. He presented with medically intractable partial seizures, no history of hemorrhage, and no deficit preoperatively. Functional MRI, finger tapping showing the nidus here, and finger motor area is located posterior to the nidus. And tractography also showing the same result. Here is a upper extremity corticospinal tract, and here is the lower extremity corticospinal tract, which surrounding the nidus. So at this information, which modality do you use for the IOM in this case? So SEP is used for the transcranial cortical phase reversal to determine the central sulcus, and MEP stimulation with the cortical tract and transcortical and direct cortical stimulation is used, and transcranial and direct cortical stimulation is used, and recording with EMG and D wave from spinal cord is used in this case. This is mapping before removal. We can identify the mapping. So this is a nidus phase reversal showing the identification of the central sulcus, upper extremity area, and lower extremity area here. So nidus were dissected circumferentially. So in the dissection at the deepest part, you can showing the decreasement of the D wave here. So warning signs, alarm was transferred to the surgeon, and the dissection was ceased, and then the D wave amplitude recovered here. So this is the summary. You can see the decreasement of the before and after nidus dissection for the round pronator muscle area, and also foot area here. You can see the decrease from the 20 to 30 microvolt. However, the over 50% of the control is preserved. So this is a cortical and subcortical mapping after removal. You can see the smallest threshold here, 4 milliampere for the RPM. This is the nearest position for the corticospinal tract. So this is a post-operative course. You can see the nice dissection of the nidus here. Let's move on to the brainstem cavernous malformations. This is part of the summary. So pontine, and pontomedullary junction cavernous malformations. EMG cannot be elicited patient with a severe preoperative motor weakness. However, sometimes the EMG direct stimulation, monopolar stimulation, and can elicit cortical EMG by mapping. However, sometimes it is not recordable. Let's show about this case. This is a case with the pontine cavernous malformation, right anterior petrosal approach was taken. This is the right cranial nerve 5 root entry zone and pons, and this showing the some hematomas here. So we mapped by monopolar stimulation thresholds shown here. So we incise here with complete confidence with here. So this is a summary of the result. Primary motor cortex were identified with functional MRI, SAP, and MEP. Subcortical MEP mapping was used to localize cortical spinal tract and determine the safe entry point in the patient with AVM and brainstem cavernous malformations. EMG MEP were not recorded in extremities in the patient with severe motor weakness preoperatively. Operative manipulation was ceased and manipulation site was changed when MEP monitoring finding aggravated. No permanent motor deficit appeared in the patient who showed only transient MEP worsening. So the role of the MEP in the AVM brainstem cavernous malformation surgery, it is possible to detect warning sign by MEP monitoring intraoperatively. MEP can facilitate to preserve the motor function when cessation or change of the manipulation site is encountered on aggravation immediately by MEP. And MEP monitoring and mapping are useful to preserve motor function in surgeries for regions in and around primary motor cortex and cortical spinal tract. However, limitation exists in the patient with severe preoperative motor dysfunction, and this should be recognized. So this is a summary of my talk, and I would like to announce you about the third Asian Oceanian Society Society of Intraoperative Neurophysiology annual meeting coming up to next May. So please visit this URL. Thank you again for your kind attention.
Well, thank you, Professor Kodama. And now we are open for questions from the floor. And anyone have a question? So I have my question. And do you routinely use in the D wave monitoring during the cerebrovascular surgery? And what happened if for example, the aneurysm, what happened if premature rupture happened and the technician warned you of changes in NP and SSEP? Will you turn to the D wave or you just trust the message from the NP?
Thank you very much for your question. Understanding is if I usually don't use that for a cerebrovascular surgery. If I use it when I use the D wave monitoring, I use just apply wave to the primary cortex lesions. I present it in the primary cortex, the cortex AVMs. Usually for the aneurysm in the ICA, MCA, we just do the transcranial MEP and have muscle recording. So this is one answer for you. And the other the premature rupture, after premature rupture. So it's apply occlusion, wait unit, the operative field. We apply the proximal occlusion by temporary creep. the MEP and SEP will decrease. But just 5 or 10 minutes is my experience. At least the less than 5 minutes temporary clip doesn't matter any big problem. So just stabilize the condition, then established the condition. If they have the MEP after the premature rupture, we don't use the MEP if the condition permits. Thank you.
Thank you, Professor Kodama. And anyone have questions? Okay, because of the tight time frame, and the session will move to the next speaker and will be introduced by Professor King. Please, Professor King.